Welcome to the eView module on the parasternal long axis view. Before starting this module, let us recall that the parasternal long axis view, also called the PLAX view, is one of 5 key views that together make up the echocardiographic exam called focused cardiac ultrasound. The 5 views are subcostal long axis view, subcostal IVC, parasternal long axis view, parasternal short axis view, apical 4-chamber view. To see an ultrasound video clip of each of the 5 views, click on the colored buttons in the diagram. Apical 4-chamber view, parasternal long axis view. At the end of this module, you will be able to identify the anatomical plane of the heart visualized in the parasternal long axis view, identify heart structures appearing in the parasternal long axis view, understand how to acquire images from this view, and recognize and troubleshoot suboptimal images. We will now review the ABCs of the parasternal long axis view. We will start by reviewing access in the parasternal long axis view. As previously noted, the heart is cut by the ultrasound beam in a ventral to dorsal axis, cutting the heart's left side structures along its longitudinal axis. As previously noted, because the sonographic image is flipped horizontally on the screen, the base of the heart appears on the right side of the sector, and the apex of the heart appears on the left side. Next, we define the boundaries of the parasternal long axis view. This is an interactive slide which will enable you to identify the walls and valves in the parasternal long axis view. Using the mouse, hover over the image to identify the various structures. Left ventricular inferolateral wall, anteroseptum, aortic valve, mitral valve. Lastly, take time to identify the heart chambers visible in the parasternal long axis view. Use the mouse to hover over each structure to identify its name. Left ventricle, left ventricular outflow tract, right ventricular outflow tract, ascending aorta, left atrium. Now that we have a good understanding of the sonographic anatomy, we can proceed to learn how to obtain the parasternal long axis view. Probe manipulation utilizes terminology which is consistently used in the clinical setting, but may differ from the common use of the term. Getting used to the clinical terminology of probe manipulation is helpful to ensure consistency. Click on each photo to view probe manipulation and its corresponding terminology. Tilting also involves angling of the probe, but unlike rocking, the probe is angled in a plane perpendicular to the indicator. Rocking means angling the probe toward or away from the indicator. To summarize probe GPS of the parasternal long axis view, grip the probe like a pen, position the probe in the left parasternal area with pressure applied perpendicularly. The indicator should be pointed towards the right shoulder and the head of the probe directed towards the back, perpendicular to the patient's body. Next, we'll review a few troubleshooting strategies to help correct common technical errors and challenges that may get in the way of an optimal image. In this image, the interventricular septum is not horizontal as it should be in an optimal parasternal long axis view, but rather has an oblique orientation. This indicates that the ultrasound beam does not cut the heart perpendicularly. In the majority of cases, this is due to caudal interrogation of the heart. Sliding 1 or 2 intercostal spaces up will correct the problem. The septum will now appear horizontal. An effective way to improve the quality of the parasternal long axis view is to position the patient in the left lateral decubitus position. This will bring the heart closer to the chest wall and place the left lung away from the parasternal area. Another maneuver that can help in this situation is to position the patient's left hand above the head to open up the rib spaces and improve image acquisition. In fact, the left lateral decubitus position is the standard patient position for this view in the echo lab. With critical care patients, however, this position may not always be possible. We've come to the end of the parasternal long axis module, and the key concepts are summarized here for your review.